everyone, and welcome to another episode of Health with Dr. Yvette. This is a podcast that aims to correct myths around health. And today we're joined by the first ever specialist to come to this podcast. We have Dr. Chuman Jovu. Dr. Chuman Jovu is an oncologist. To be specific, he is a clinical and radiotherapy oncologist. Did I get that right?
Yeah, sure. Yeah.
Welcome.
Thank you very much, Dr. Maseken. Thanks for having me.
The pleasure is mine. Thank
Great.
you so much for joining us today. Why oncology?
Why oncology? So you're trying to find out why I did oncology?
Yes, why oncology?
You're trying to find out why I did oncology?
Yes, why oncology? Because when I think of oncology, I mean oncology is the study of cancers, right? Yes. When I think of cancer, I think of something that's sad, and I wouldn't picture myself doing oncology, especially in our setting. So, what made you do oncology?
Yes, I mean, as you know, medicine is very diverse. And in its diversity, you have very special component of oncology, which, like you rightly put, focuses more on cancer, types of conditions. Now, oncology is very broad. So there are other sub-disciplines of oncology that come in. If you look at the actual oncologic therapy, it stems, from, as far as surgery. So it's broadly divided into, categories, right? So you have what we call the surgical component of oncology, which is like the surgical management, and the non-surgical component of oncology, which has got all these other subclasses. So with the surgical component, it's straightforward. So pretty much somebody who's got surgical skills and well specialized in oncologic surgery, they'll be able to render that type of modality. For non-surgical component of oncology now, it looks at, techniques that are different from surgery. So you look at radiotherapy, you look at things like chemotherapy, biological therapy, hormone therapy, all different lines. And now there's what is being called targeted as well as immunotherapy that is, evolving from that. So now why oncology? As you know, medicine is broad. I mean, we get patients from all across labels. And the first thing is first, if you want to get into something, it has to be of your interest. So for me, it was the complexity and the challenge that comes with it. A lot of people, like you say, fail to deal with it because of the emotions. And I mean, that's a myth, like you're saying, we're trying to break the myth because they're good stories to read. I mean, we see the bad side of it because we tend not to do quite a lot in terms of primary and secondary prevention. And we focus more on tertiary prevention. But there is a good side. And the good side is that patients receive treatment, they get treated, they get cured, and they go about going their normal lives just like anyone else. So I've had this very strong passion for oncology. And I mean, this strong passion was born when I was in my undergraduate times. And my best friends would always tell me about it, that like, you love this stuff very, very well. And I remember one of our undergraduate texts that we used to use in pathology. It was like a text of reference. So there was a chapter there, which was chapter 6. The whole lot of chapter 6 was neoplasm and oncology. And that was like my best chapter because I knew it from the start, to the end. So I had this interest in it passionately, and then I decided to grow in it. And growing it meant that I needed to acquire skills, and knowledge so that I can render this service to my patients effectively.
Okay. So how has been your experience practicing oncology in Zambia?
So I mean, that's very good question and interesting. So I believe in one thing. This what I always tell my friends and myself in what is called adaptive living. So if I say practice in the first world, then I gotta adapt and practice like what somebody else in the first world would do. If I'm in the third world, it's pretty much going to be the same. Adapt and practice what you get to see in the third world. I must say it's been very, very challenging in our country. Reason being that there's a lot that you can do with oncology, and especially when you look at the other modality of, say, radiotherapy, it's highly, very, very technical. The technology around it is like so immense. It keeps growing, day by day. Systems keep changing, day by day, and then getting to a place where you're in an environment where you are not able to. You got the skills, but you cannot use these skills, to practice what you love practicing. Become the challenge. So back in our country, the biggest challenge has been, first of all, just access to service. You find a lot of our patients present quite very late because a number of them, have got very limited access to, healthcare service. Others as well, even when they get access to service, for them to just meet up what is required for them to, be fully worked up and start the treatment. It takes a very long time. Even when that is done, if they have to soldier through the whole treatment process becomes problematic. I'll give you an example. Say somebody coming from as far up in the north in Mansa, and they have to be traveling all those kilometers to Lusaka every 3 weeks to get chemotherapy for about 8 to 6 months. That's quite challenging mentally to maintain, and financially not, enabling for them. So those are some of the social challenges that you get to see. The other issue is now just at the practice level. You find that you have a very limited equipment that you can use to pretty much offer your comprehensive care for most of these oncology patients. Currently, like, radiotherapy has been down for quite some time, so it's been difficult to have to give that comprehensive oncology care. You give a part of it, but you cannot consolidate it because this other modality is simply just not there. You don't have other high-tech diagnostic staging equipment that can help redefine and break down some sort of discordancy in certain areas that you have to get. And one of the biggest challenges, like the unison between other units, because oncology doesn't run by itself, so you pretty much run with other specialties as well. So trying to get other specialties together in different fields has been very, very challenging in this country. I've seen the gynae one has been doing quite well so far because it's done virtually online. So you get to have people from different corners of the country join in and come in, to discuss most of the cases. I think the breast one has been running well. The GIT was introduced, and I think it's doing pretty well as well. But there's still quite a lot more that should be done to make sure that you cohese with us other specialties. Because technically, before a decision is made on what type of treatment you have to give for a patient, you have to congregate what is called a tumor board. This board comprises specialties from different areas: surgeons, specialized nurses, palliative care nurses, physicians, different teams, and they all sit together to discuss a case. And it's those concerted decisions that are made to say, this is the route that we're going to take. For instance, if the board decides we go the surgical route, then the surgeons take over the case and manage. If they say it's too much for surgery, let's go the non-surgical route, then my team takes over and manage. Or if the surgeons operated, but they still feel the feedback from pathologists that there's still high risk features that could still make this disease come back again, then recommend for more treatment to consolidate what the primary treatment was.
Okay.
Yeah.
So would I be right to define cancer as a disease that how can I put this? A disease that causes the abnormal growth of cells?
Yeah, that's great. The simplest way to define cancer is it's a medical condition that is described by abnormal growth of cells that have potential to spread to other parts of the body. That's
Okay.
the easiest way to define it. But I
Mm-hmm.
mean, technically, yeah, you're a doctor. If you wanted to get a little bit more technical, you know for sure that the word cancer comes from the Greek Latin word for a crab. You
Mm-hmm.
know, the way that a crab is the aquatic organism. I mean, it's got the body and some strands,
Mm-hmm.
around it. So that crab is called cancer in Greek and Latin.
Yes.
And that's because the nature of these abnormal cells tend to grow like that crab. So because of that crab-like growth, it's because it's called what? A cancer. But I mean, technically, any new cell that comes in a body is again defined by the Greek Latin word to say neoplasm. From the word neo means new, and the
Mm-hmm.
plasm is a cell, right?
Mm-hmm.
And then you know for sure that with these new cells, they're those that are not really harmful. They just have aggregates of cells, and perhaps the greatest discomfort they'll give you is the mass effect that comes in with the aggregation of the cells, or the cosmetic effect if they're growing outside, the body, but they don't cause so much of the harm. Like they don't have potential to spread. Things like fibroids and all
Mm-hmm.
those things. I mean, those are benign. But then there are this group of cells which are abnormal cells. So they grow where they start from, and because they grow where they start from, they feel that's not enough. They still have to go through to other parts of the body. So they take leverage of the different channels to
Mm-hmm.
spread to other parts of the body. So in as much as they're growing locally, they're now taking advantage, because remember the body has got transport systems as well, right? The
Mm-hmm.
blood vessels,
Lymphatic
yes, the
system.
lymphatic systems. I
Mm-hmm.
mean, the communication systems through the nerves. I mean, the cancer cells take advantage of that. If the cells break the barrier for the blood vessel,
Mm-hmm.
then they get into the blood. And because blood is constantly moving, they
Going
hitch a
everywhere.
free right in there.
Mm-hmm.
And they go wherever the blood is going. And at the next station, they make a village. They start making cells there. And, the spread starts going. So those cells that have the ability to spread to other parts of the body are what are called now cancerous cells.
Mm-hmm.
But like all in all, the easiest way to define it's a medical condition that is described by abnormal growth of cells which have the ability to spread to other parts of the body. That's a layman definition.
Yes, that's true. What are the early signs and symptoms that people can look out for?
So, you know, the cancer comes, I mean, in different parts of the body. And
Mm-hmm.
that's for one reason. Remember, the body is first made up of cells. Cells aggregate to make tissues. Tissues
Tissues,
come together to make what?
organs.
Organs. And then the organs form families and make systems,
Yes.
right?
Mm-hmm.
So that's what happens. So every cell is vulnerable. It's got potential to transform to abnormal cells. And depending on the side where this abnormality starts from, the way
Mm-hmm.
they present becomes very different. I'll look at, I like giving examples of, the top four cancers that we see in Zambia. For
Mm-hmm.
instance, in the top one, we have cervical cancer. And you find with the cervical cancer, usually, because the cervix, which is the lower part of your uterus, pretty
Mm-hmm.
much like just at the neck of the uterus, is inside the human body. It's covered. So it's very difficult to see if those cells that are growing abnormally are what? Aggregated. So, but you find that as the disease is growing, in the early phases, it doesn't even show any symptoms at all,
Mm-hmm.
and one may think they don't have it. But as the masses of the cells starts growing bigger and bigger, then it
Mm-hmm.
starts becoming problematic. Start experiencing pain in the lower part of the abdomen. They start bleeding every time they have coitus, or they start getting uncomfortable every time, they have a sex. And, they get to experience some, abnormal vaginal discharge,
Mm-hmm.
foul smelling usually. And when it's very, very advanced, they get to have this persistent backache. And sometimes some organs around the area where the cervix is, like the
Mm-hmm.
rectum and
The
the bladder,
bladder.
tend to be
Yeah.
affected as well. They can't, control the urine and that, you see. So the presentation is diverse. Take, for instance, breast cancer. breast as well, the breasts are outside the body. So, but the lumps that grow, they're pretty much inside.
Yeah.
So for most of the ladies and some males, because remember breast cancer affects males as well, they don't take time to feel, what is inside their breast. So they would not know if there's something abnormal is growing there. But usually it will come in as a very painless lump that's growing slowly, and eventually that painless lump may become, big, so big that it blocks some of the tubes that help to drain water in the breast. And when those tubes, the lymphatics, are blocked, then the breast starts what? Swelling. All right. And then now it starts affecting other areas around in it, like pulling the skin right tip to it, getting the nipple towards where those lesions meet, the nipple comes disfigured. And then because there is a skin that is being, subjected to the tension, eventually the skin opens what? Opens up and forms an ulcer.
And
So
that's when people present.
and then that's when people now want to go to the hospital, like,
After
oh
it
hell,
yeah.
What is this? So depending on the site where the abnormality of the cell starts, the presentation does vary from there.
Okay.
Yeah.
So you've mentioned cervical cancer as being one of the top cancers we see, breast cancer. What other cancers do we see? Like the top 5, maybe?
Yes, so essentially, like in our country, of course, topmost is cervix. Cervical cancer is the number one that is recorded. And also, it's the number one cause of cancer-related deaths, mortalities. So second to that is breast cancer. Third to breast cancer is prostate cancer. And then after prostate cancer, it's these hematology malignancies like lymphomas, and then other sarcomas like Kaposi sarcomas that's coming because of the HIV prevalence.
So those are the ones that we're seeing.
These are the top. These are the common top 5 that we get to see in our country.
And in children, what are the common ones that we're seeing in Zambia?
It's children as well. It's the same. Mostly the hematological, but of course not the cervix. It's mostly hematological malignancies. But then they get to have a lot of like urogenital tumors, like Wells tumors, the nephroblastomas, and neuroblastomas as well. Sarcomas are quite common, and a lot of neuro-related malignancies. But the thing about children is that they respond very well to treatment.
They're quite resilient. Children are quite resilient.
They respond very, very well to treatment.
It's very, it's amazing. I get encouraged by the way children respond to treatment, even infections. It's really good. I just wish like we would respond like that. So are there any things that predispose us to cancers?
Yes. So in pretty much the cancers, there's what we call risk factors.
Yes.
And like we said, that depending on the different types of, like different sides of the cancers, the risk factors are what different. So there's certain agents that, modifiable. So when we say modifiable, like we can do something about them to try to stop, those leading to cancer. And then there are also those that are non-modifiable. So the non-modifiable ones are the ones where we literally have no control over. By virtue of one, being subjected to those type of risks, the chances of them getting that cancer gets very high. I'll take an example of cervical cancer. We know very well that it's caused by a virus. This virus is called the human papilloma virus, and we look at the high risk strain. So it's the persistent infection with this high risk strain for human papilloma virus that eventually leads to the growth of these abnormal cancer cells. Now, how is this virus spread? So it's literally contact spread. And the easiest contact to have this virus to the cervix is sexually. So you find high-risk sexual behavior tends to pause or have these or different strains of these viruses deposited on one cervix, and then over time they gain ground to break through the cells and then start growing abnormally. But again, it's been shown also that patients that tend to smoke a lot, those that are of low socio-economic status, the ones that immunosuppressed as well, tend to be more at risk of having this virus progressing into cervical cancer. For things like breasts, again, it's things that you can do stuff about, and those that you can do nothing about. But mostly, what we see, there's a genetic pattern. So there's a family of genes called the BRCA genes that are responsible for different types of cancers, and these genes are passed on from generation to generation. So because of that defect in those genes, the chances that one would have abnormal cells start growing and develop into cancer tends to be very, very, very high. But again, high risk behavior, smoking excessive intake of alcohol, all these other things come to play.
Smoking is
terrible. So smoking is responsible for almost all the cancers that you can ever think about in the body side. One, for sure, we know that it's responsible for lung cancer. Almost all the lung cancers that you see.
So just on that,
yeah,
are we seeing an increase in lung cancer? Because I think Zambians are smoking more now, and actually came across something that said that in the next 10 to 20 years we're going to see an increase in lung cancer because of this increase in smoking that we're seeing in Zambia.
Well, I mean, quite certainly the amount of smoke that you take in is related to one's risk of developing lung cancer. There's no two ways about it. One of the most common causes of lung cancer is those carcinogenic toxins that you get from cigarettes. So if there's an increase in any habits that relates directly or indirectly to smoking, then definitely you can anticipate that the cancer rates, cases are going to be very high. But this is dependent on how much, smoke or cigarettes are taken in. So there's like a particular pack-year history that would pose one to be at risk of developing lung cancer. We get a challenge in our country, and the challenge is we don't have a readily available capacity to diagnose most of these lung cancer cases. So we're coming from a time where it was even difficult to make a diagnosis of it, histologically confirmed, to a time where we've shifted a little bit. We still have sort of like some technique to use, but it's still not adequate enough to give out the extreme, correct diagnosis that we need. But I will tell you frankly that the time that I've been around here, we've treated quite a good number of lung cancer cases. So that should tell you that we're not immune from not having these cases.
Okay, so what's the prognosis for lung cancer?
So it's pretty much like any other cancers. If it's detected very early, and I mean it depends on the type of lung cancer. Broadly, we have the two main types that we call non-small cell lung cancer, which is a family of cancers that's non-small cell. So you look at your adenocarcinomas, your squamous cell carcinomas, and pretty much these are the histological subtypes. Then we have the so-called small cell, lung cancers. So these ones are rapidly growing but tend to respond quite very well to treatment. So the key is about presentation as well. So if it's detected very late, the prognosis is very poor. But if it's detected very early, the prognosis is relatively good, and people can still live quite a longer life. What we have seen, remember when I was talking about treatment modalities, there's a component I talked about called biological treatment, which pretty much looks at immunotherapy and targeted therapy. So much of the works and efforts in targeted therapy and immunotherapy have been in this part of tumor sites, which are the lungs. A lot of targeted treatment that is being used is being applied in lung cancer, especially for those cases that are very much advanced. And again, unfortunately, we don't have yet any of these drugs registered in our country. So if one has to be put on that, we have to sort of like, make a special request for them to be imported in the country so that the patient can get them through.
Okay, so I would assume someone who has lung cancer would present with a cough, chest pain,
Yeah.
like non-specific
Very non-specific
symptoms.
Yeah.
And
But I mean, sometimes it's pretty obvious. Yeah, they'll lose weight over time. Then they'll have, cough that is stained with blood, hemoptysis. And of course, they're going to have, pain. And then most certainly, they tend to have difficulties to breathe. So the shortness of breath tends to come in. And then you do an x-ray and you find that this person has got a massive mass in their lungs. Sometimes they present indirectly. So you find they tend to lose some of their functions neurologically. And then when they're seen by the neurologist, they do the imaging, they find that they've got a lesion in their brain. And our dearest neurologists are good at, excising those. So they'll go in, take that lump out, take it to the lab, and then they tell, oh, this looks like something that could have been coming from the lung. And then we do the x-ray and find, oh, there is a lung mass in there. So some of the cases tend to be picked up indirectly like that.
Okay.
Yeah.
So the other cancers that we mentioned are common are prostate cancer.
Prostate cancer.
So prostate cancer probably present with non-specific symptoms as well, or maybe are there specific symptoms?
Yes. Well, I mean, there's certain things that you expect at a particular age. So, with prostate cancer, one of the risk factors is the age. The older one is, the risk is for them to develop, prostate cancer. So by having obstructive urinary symptoms at an age that's above the age of 50, 60, 65, then that raises suspicion already. But I mean, it's very easy for prostate cancer because you can pretty much just do your blood count. So you draw your blood, send them for analysis. If the PSA levels, which are the prostate-specific antigen levels, are like very high, then that raises a red flag. So then you go in further, you examine clinically, feel the prostate, and I mean there's a way that it feels if it's cancerous. And again, if that raises an index of suspicion, then you take a small piece around it and take it to the lab, consult the colleagues from pathology to confirm if the cells that are there that are producing that PSA are really cancerous or not. Yeah.
Okay, that's interesting. I noticed among the top 5 cancers, you didn't mention colorectal cancer. Is it?
Yes, it is quite common as well.
It's common?
Yeah, it is quite common. But of course, I mean, those statistics I was giving you are for our setting. So in our country, what we see are those mostly cervix, breast, prostate, the lymphomas, and Kaposi sarcoma. But colorectal is quite common as well. Yeah.
Okay. Are there any jobs that put you at risk of getting cancers?
Like we said, some of the risk factors are modifiable, which pretty much like are environmental, and then other risk factors, are non-modifiable. In terms of occupation, I mean, most of the people that worked in rubber plantations for a very long time were noted to be at risk of developing bladder cancers. And pretty much some of, the people that tend to work in the mines where they're exposed to things like asbestos and all that, they tend to have a lot of lung-related malignancies. Lung cancer being, one of them. So these are just some of, the jobs that do that. And I mean, health workers too, for instance, if you look at your most of your hepatocellular carcinomas, one of the risk factors is, infection with hepatitis B virus, right? Which one can get exposed to from occupation, especially if they're not vaccinated against that. So by and large, I mean, yes, occupation tends to play a role directly and indirectly to being part of the risk factors for some of the cancers.
Okay. So in the beginning, you mentioned that being a low socio-economic status is also a risk factor. Now, I just got thinking, like in our setting, is it that most of these are actually peasant farmers and they handle these chemicals, and most of them don't even wear protective clothing. Could it be one of the things that
we're not quite certainly. Well, of course, there's been some association with certain, stuff that people tend to use with particular cancers. I mean, like what was seen some time back in KZN, where not sorry, KZN, like the Eastern Cape of South Africa, where there is this traditional way of trying to make some kind of like clay pots, right? Those clay pots that they brew and then they put like traditional beer in it and drink. It was found that a lot of people that were coming from that region were relatively more at risk of developing cancer of the throat, which is the esophagus, relative to other people. So that may just be one. But I mean, when I was talking about low socioeconomic status, it's mostly to do with cervical cancer. It's the main risk factor for cervical cancer for, 3 reasons. The first reason is they've got no access to vaccination. When you are vaccinated against HPV, you cut down on the risk of you developing cervical cancer by like tens and tens of folds. That's why we don't see it in the Western developed worlds. I mean, we don't get to see a lot of those cases or cases reported as much as they're seen in sub-Saharan Africa because they've got well-established vaccination programs. I mean, other than that, it's screening. The patients, the people that have low socioeconomic factors don't tend to have access to screening services. And by so doing, they miss out on an opportunity where if the disease was developing, because remember it starts with precancerous lesions before it develops into the main invasive lesions, they miss out on the window where those precancerous lesions can be picked out and be treated there and then. And then the other thing is, again, access to care. They've got this mass growing on their cervix. They just don't have the capacity or ability to visit a health center. So this thing, keeps growing until it's so much advanced to a point that it becomes very difficult to have it treated.
Okay.
Yeah.
Have we successfully sent out people for treatment? I think a few weeks ago I read something where we were going to be taking patients to Tanzania for radiotherapy treatment. Have we successfully sent people out for treatment?
So the thing, I mean, that's a national program, right? And I mean, like in our country, there's always been systems that have been in place to try to give a service to the Zambian people that is not offered in the country, of course, supported by the government. So it undergoes rigorous scrutiny. There's a board that, reviews those cases. And only when that board acknowledges that, yes, these cases have to be supported, then they're recommended. And of course, the government takes it over from that. Now, until a couple of years back, radiotherapy became one such service because, I mean, we're not able to, to give it in our country because our machines have, sort of like reached their lifeline. So this part of the service now fell on what the already system that was there is. So radiotherapy was just added as a service that's not available, but now can be offered through this channel where the board has to look at the reasons why it has to be given and who has to get it, and when the board recommends, then it goes. So these mechanisms have been there even before the cancer center were there. That's how people used to get treatment before the center was established. But I think the cost of doing that was too much. And that's how come through the support of other stakeholders and organizations, we had an operational cancer hospital coming in. So that is still being done. There's still been quite a number of patients that are being taken abroad. Of course, mainly India. They used to go to India, but I think, like you said, like we saw it being published in the media. I think the government had engaged a center that is in the neighboring country to try to, bring it in like as a filler sort of solution as we wait for them to work on the machines or bring in the machines so that service can be retained back in the country.
Okay.
Yeah.
I'd like to hear your personal opinion on this. From the time we opened the cancer disease hospital, is it that we are having more cancer cases, or now we're just able to diagnose more?
So it's two ways. So two ways. The first way is, yes, we've seen an increase
Okay.
This is because we're looking at the statistics because I mean, to date, we only have cancer disease hospitals. There are so cancer treatment centers in our country. So we are looking at statistics from that. I mean, I think when they started in 2006, I think there were just over 300 patients. In 2007, it was over, 419 patients. And then when it went all the way to, sometime in 2019, where we saw over 3,000 patients, new patients being seen at the cancer diseases hospital. So when you see that trend in terms of statistics, yes, there's been an increase. But a lot of factors lead to that. People are now getting to be much more aware. And like you're saying, there's been an improvement in the diagnostic capacity, because if you recall back in the years, it was difficult even just to get histology. But now we don't only rely on the state laboratories to process those histology. There's been on board, these are the private laboratories that have come in that are able to analyze these samples. So the diagnostic space has been expanded. And that brings in a confounding effect, because, I mean, you pretty much don't know what the status quo was previously. So you can't compare it to what it was previously, because the base was not the same. But what we can say, yes, we're able to diagnose better now. And from the stats that we're seeing, the cases going up. I mean, one would argue that there was a dip from 2021. Yes, there was, just like there was a dip in any other cases that were non-imagined. That was mainly because of the COVID, pandemic that had hit the world at the time.
Okay.
Yeah.
So, do we have any community engagement programs or cancer outreach programs that
Yes.
Educate
Yes.
the public about?
Yes, so there's a very big department at our National Cancer Center, and that looks at not only epidemiology but public awareness and community engagements. And I mean, it's good that you chose this topic in the month of February. And in fact, on a day when we were commemorating World Cancer Day. So remember, yes. World Cancer Day was on the 4th of February, and because that was a Sunday yesterday, the commemorations were pushed to today. So across the country, there are a lot of activities, and I think part of the team from the National Cancer Center had gone to one of the provinces, I think it should be Southern Province, in Choma to be specific, where they had quite a number of activities lined up to try to, sensitize the community, screen the community, and then just, spread the word to say that this cancer is real, it can be treated, it can be prevented, this is how you prevent it, this is how you pick it up early, if it's there. So these programs are there. So Feb is World Cancer Day. Month of October is, Breast Awareness Month. Yes. So there are all these.
Month of January is Cervical Cancer Awareness
Month. Awareness. So from period to period, there are always these awareness programs that run.
Do we have a Prostate Cancer Awareness Month?
Yeah, well, we do have it, and usually when we have a particular awareness program for a particular cancer, all the screenable cancers tend to be banded together. And that service is going to be offered as well.
Okay.
Yeah.
Do we have support groups for our cancer patients? And is there do we have stigma around cancer even now?
The stigma is there. I mean, stigma is very, very much alive, and sometimes that's what prevents. The thing about stigma is two ways. One way is, they've got cancer. The worst part of it is self-stigma, where somebody has been diagnosed with cancer, but they're in denial, and they don't want to get any form of treatment because they believe if they get subjected to that treatment, then they won't process through. We've seen quite a lot of patients that go through that. You advise them to say, look, this thing can be treated before it goes to other parts of the body. Let's treat it so that it doesn't eat you up. But the sense of somebody just being told that you have to get chemotherapy or radiotherapy, they probably just think like it's the worst that you can have, So, and that's one of the reasons why these awareness programs are there, to break some of those stigmatic, tensions that are there in the community. There are support groups, mostly being run by some NGOs, some of, cancer survivors that have, put up groups together and societies together and trying to spread awareness and encourage people that are on treatment or being diagnosed with the disease, and also just try to support, you know, in the provision of cancer services in whatever way that they can.
Okay.
Yeah.
Well, the thought of chemo is scary. I mean, the way it's portrayed. Okay, not only in movies, but even you see these cancer patients who online showing you what they're going through. First, they have the hair, of course. The first thing when you think of chemo, first thing you're thinking of is someone becoming bald. Um, Even the way they look quite pale, and they generally don't look very healthy when they're going through chemo. Do people recuperate after the chemo? Does the hair grow back?
Well, like any other treatment, you get side effects from pretty much the different treatment, but even from surgery, and side effects in the acute phase. Those things I tell you about, infections and all that, risk for bleeding and all those things. Same. I mean, even just your Panadols, your antibiotics, they have all this range of side effects, and the same with chemotherapy. Um, and I mean, before chemotherapy is given, there's a lot of things that are done. So there's what we call pre-chemotherapy preparation and workup. So you extensively want to check whether somebody's fit enough, not only by the general look of their body, but like just what the general biological picture, metabolic picture, kidney functions, liver functions, can it handle and support the chemotherapy? And then of course, you anticipate side effects, so you prepare them for that. You give what is called the pre-medication to try to bring down the side effects so that this treatment can be tolerated. The whole essence is to try to give the benefit against these side effects that are stigmatized everywhere. You know for sure that the benefit is the cancer will be treated. And these side effects can be suppressed with supportive treatment. And like you say, it's for the hair, it's reversible and transient, alopecia that comes in. But the time you finish your chemotherapy, your hair tends to start growing back, gradually. So, and I mean, it's that background that people are scared of that the evolution of treatment is still going on. Remember, in the past, we never even used to have biological therapy. But now we're now looking at targeted therapy, where you don't pretty much use chemo that goes around. You target the area that's driving the cancer to grow. And that's what you block. And by so doing, you give the treatment and spare some of the normal cells and reduce on the side effects.
Okay.
So yes, chemo has been portrayed to be intense, but I'll tell you, I've treated a lot of people on chemotherapy. Others go through it with very minimal side effects. Others go through it with just moderate side effects. And those that get extreme side effects, we do give them supportive medication to bring down those side effects.
Okay. I hope that encouraged someone to to start treatment. What do you mean when you say a cancer has gone into remission?
So I mean, there are different terms. Well, remission is pretty much, so it's like when you give treatment, right? And you've sort of like eradicated the site where the cancer was, pretty much like completely. It's like you've cured somebody, right? So there are pretty much like three things that you expect when somebody's on cancer treatment. One of the things, I think your intention is to cure it, right? You want it to treat it. But even when you're intending to treat, the cancer may respond to the treatment and get, cured or go into remission. So pretty much like there's no disease. You just put somebody on surveillance to just check whether there are any features that, it's coming back. Then there's a part where it only partially responds, So it's been treated, but not completely responded. So a bit of it is there. And there's some kind of like residual disease that has potential to grow again. Then there's now like progression even after the treatment has been given. So this is like resistant to the treatment that you're given, and then it keeps just going on. So in a nutshell or layman's term, When somebody says my cancer went into remission, they're pretty much saying I was treated for this cancer and I don't have this cancer active anymore. Yeah.
But it has.
There is a possibility, yes.
Of it
There are
coming back.
possibilities that even when it has been completely treated, there's still a possibility that it may come back. That's why we don't let go of cancer patients after treatment. We put them on a follow-up plan, and the minimum follow-up plan usually is 5 years.
Minimum. So
yeah.
After. Oh, okay.
Yeah.
That's minimum.
That's a minimum follow-up usually. So we see them in
So
the first year, see them in the second year. We
year.
keep seeing them because we want to keep monitoring this cancer that we treated, so that if there are any red flags, we intervene.
Okay.
Yeah.
There are a few questions that I wanted to, a few myths actually,
Okay.
that people talk about. So some people believe cancer has no cure.
Yeah, so that's a myth. Cancer is curable and treatable.
Yes.
The only thing is you have to come to the hospital
Early.
So it becomes difficult to treat if it's spread to other parts of the body. And that's because somebody didn't want to go to the hospital. They waited until the cancer progressed or involved other parts of the body to go there. So that way it becomes very difficult to treat. But if it's picked up early, it's treatable and curable. And that's why people dedicate their time to go to the community, sensitize, bring out those awareness programs so people are encouraged to say when you have something suspicious, you don't have to wait and delay. You go straight to the hospital.
Some people believe cell phones cause cancer.
No, there hasn't been any direct documented study to link that.
There are people who believe surgery causes the cancer to spread even more, and these people actually refuse biopsies.
No, because I mean, it's remember this surgery is done by specialized people. So just like they're general surgeons, they're oncosurgeons. Oncosurgeons are a type of surgeons that have been trained to specifically treat cancer conditions. So they know how to approach and how to take out these cancers. And by so doing, people should not be worried about the seeding that they're always talking about.
Okay.
Yeah.
What's your take on use of herbal medications?
So I always tell,
cancers?
yes, that's very big. We see a lot of people get on that. Some of them will tell you, others will not tell you. I mean, I'm a scientist, so I pretty much know nothing about how the herbs work. But what we see is that the herbs tend to crush people's kidneys a lot. And we need kidneys to give cancer treatment, especially chemotherapy. If the kidneys are not functioning well, then it becomes difficult for us to give chemotherapy that's going to treat or cure the cancer. So that way, the options to give treatment are already narrowed. So for the herbs, I mean, everyone has got the choice to use what they want to use. But I mean, I'm not an advocate of the herbs for one reason is I don't know how it works. Two, I don't even know if it's effective. And three, I see some of the damages that it causes on some patients that tend to be on it. When they see that things have not worked, that's when they come to the hospital to try to see if that can be, kind of like remedied. Yeah.
Some people believe that a high sugar diet predisposes you to cancer.
Yeah, I mean, there are dietary factors in our different ways, not only excessive sugar, excessive fat, excessive red meat. For instance, let me, talk about breast cancer. One of the types of the breast cancer is the one that feeds on hormones. So if somebody is obese, obesity is one of the risk factors to drive that particular type of breast cancer for the reason that the body is going to convert the fats in the body to make the hormones. And when the hormones are being made, they're feeding the cancer cells and driving the cancer cells to grow. So that can be achieved, of course, by doing regular exercises, cutting down on the diet that's going to stimulate that excessive growth, and that way reducing on the endogenous supply of the hormones. So yes, the dietary factors that are associated with cancers, and it's always important that, of course, you maintain your balanced diet, but you live, healthy.
Some people believe that sucking of breasts prevents breast cancer. Is that true? Sucking and squeezing them.
Well, it's breastfeeding. So breastfeeding has been shown to be a little bit protective. So for those mothers that have had breastfed their mothers, the risk for breast cancer is relatively less than those that have not breastfed.
Okay.
Yeah.
And for prostate cancer, is it multiple ejaculations? No.
Yeah. So there's never been a conclusion to that. Even all the studies that have been done in that area, there hasn't been any concrete conclusion to say that the more you ejaculate, the more you have a reduced risk of developing.
So that's a myth.
Yeah, kind of.
Yeah, probably a man is the one who came up with that.
Wow. You wouldn't be surprised that even a woman was driving that because they, yeah.
Okay, yeah. It's very possible. Ah,
It's a two-way thing, isn't it?
yes. Yes, it is definitely a two-way thing. But thank you so much for joining us today. Do you have any message for our listeners today?
Yeah, well, thank you so much for hosting me. It's been great to talk about cancer on the World, Cancer Day commemorations. The theme has been running on an odd theme that has been embraced for the past 3 years, which is pretty much like closing the gap, which is the care gap.
Yeah.
And the public should just know that cancer is real and that no one is immune to it. It may come at a time that you don't expect it. So for the cancers that are screenable, if you reach the time and the age to screen, it's always good to go for screening. For cancers where you can have preventative measures like vaccination, it's always great to go for those particular vaccinations, especially HPV vaccination. And again, treatment is available. When you're diagnosed with cancer, it's not the end of the world. There are all different treatment modalities that can be used to treat it. The key thing is you have to present very early, at the health center.
That's true.
And then just live healthy, exercise, exercise, and exercise.
Thank you. So you've heard it for yourselves from the cancer specialist. Exercise, eat healthy, screen. We have a lot of screening stations. We screen for prostate cancer, we screen for cervical cancer, breast cancer. All those are screened for. So make use of the services. Some of them are actually done for free, yes?
Yeah.
Yes, so this was Health with Dr. Yvette. I hope everyone learned something today from Dr. Njovu. See you next time. Bye.
Great. Bye-bye.